technology. Let's talk about the future. Welcome to Evergood Podcast, where we talk about all things healthcare, education, innovation. Three words you don't normally say in a sentence. But here we are today. It's the beginning of February, and I'm very, very excited to have a very special guest with us today, Dr. James Schlund. Really quickly, I'll try to summarize the 6 years that we worked together. And Dr. Schlund is an interventional radiologist. He is currently working in the Tahoe area. And we met because I was the founder and the CEO of Healthy Rural California and also the executive director of Buchland Medical Society, which has now changed its name. But the point here is that Dr. Schlund is on the board of Healthy Rural California. And in the time that we worked together, we did some amazing thought processes around an interprofessional healthcare campus. And so I'm just so happy you're here today, Dr. Schlund, to talk about this. It's I think between the two of us, it's something that will happen in the future
Oh my,
and
yes.
very important, especially for rural areas.
Right.
And just one last thing to say, which is on my end, which is that the thought process around this was having worked at UC Davis, I was involved with the School of Nursing as it launched, the School of Medicine, and then Behavioral Health Research and Policy. And then as I was working there, their quad at UC Davis Health started to come together, and it's really quite beautiful now. And now they even have Aggie Square. So it's just, to me, the intersection of all of the healthcare education programs in one area to address the needs of that area is how I approached it. And then I think you took it to a whole new level. So, what else would you like to say? There's so many more hats that you wear, so please do. Inter
Oh, no, it's just a delight. Kristy, thank you for the opportunity to relive how we got here and what this whole concept of an interprofessional healthcare campus, and that in this moment where access to care, especially in the rural counties of Northern California, is in literally it's in crisis, and that we have to find a way to recruit the earnest and talented young people of tomorrow out of those communities, bring them through the med ed programs that you are very much a part of, and then and are today, and then to create certificated providers in healthcare of all stripes of medical assistants and technicians and physicians assistants and nurse practitioners and MDs and DOs and put them back into those communities. Um,
Yeah.
and the concept of that was born out of this, started 6 years ago with the innovation center, collision center. How do we actually do something different? Because something different needed to be done.
Yeah.
Um, and it finally landed in this concept of an interprofessional healthcare campus where you take all of these talented, earnest people and train them together, um, in sort of the didactic educational space, then move them together into these high fidelity sim center skill based opportunities to learn your talents, and then actually to have true clinical space on campus. And so that it's it's this learn together, train together, and then do healthcare together opportunity. Because you know in complex dynamic care, and most healthcare now is complex, in that no one person can understand the totality of it. The amount of, I mean, the knowledge in medicine is now doubling every 73 days.
I'm going
Um,
to pause there to make sure people hear. Can you repeat that? Because that's a really important thing to talk about.
Yeah. The Our best estimate right now is that the sphere of knowledge in healthcare is doubling every 73 days. And it's,
Amazing.
yeah. And the rate of expansion of that sphere of knowledge is not going to slow down. Um, and that in order to create integrated teams who work coherently together and understand each other's talent sets, and you know and we have to do it. There's a lot to unpack, but that we have to do it in a way that scales to the needs of the community, so that we have to create community health people, medical assistants, physicians assistants, nurse practitioners, physicians, specialists, super specialists, and that we have to be able to actually see a person holistically for what's happening to them and then work them through the system to the level of care that they need. And so it requires this sort of horizontal meritocracy of people who are educated together, learn in their skills-based sim center space, training together, and then actually practice care together, and work, collaboratively, and not in these bin silos of how we got here, of the past.
I am recalling that, at one point we worked with an architectural firm because there's parts of things already in Chico, and that's where we were
Right.
looking at, right? And still are, I'm sure. But that there's Chico State, and they have a really good pre-med program in biological sciences. There's their School of Nursing, which is phenomenal and
Yes.
loved throughout the state. There's their simulation center, which needed to be elevated, upgraded, and expanded. And then we started talking about graduate medical education. And then I swear the second the psychiatry residency for Healthy Rural California got approved, I felt like there was like people demanding that we start rotating medical students. And I was like, hey, we just got psychiatry together, like give us a chance. But as those days went by, and that year, I think that would have been 2023, that you and I started working with an architectural firm to sort of put an image together that would inspire people to think about this. And at one point, though, you said medical schools of the future will have no walls. And I really took a step back because I was like, I thought we were building something. I thought this was the end goal is to build this
Right.
campus with a building, at least one building. And then you just tore it all down, tore all the walls down. So I'm sure you have a better way of describing that for
Right.
people like me who didn't understand it in the moment. But anyway, it's true. But that goes to this evolution of medicine at such a rapid pace.
Yes.
Why build a structure if everything's going to be changing? So anyway, let's talk about that.
No, it's a really, you are visionary in many ways, and that, graduate medical education would not exist today had it not been for you and your vision about what can happen in a rural community. So thank you for that, truly.
Thank you.
And that the for a lot of intersecting things, AI being one of them, that we lived through. I mean, people, Homo sapiens, that we
Yes.
lived through the cognitive revolution, the agrarian revolution, the industrial revolution. We survived the information revolution, um, kind of.
Still.
And yeah, you know, I, but I think the intelligence revolution that we're coming into
Mm.
will change everything. It will arrive exactly at this moment when we sort of need it. And it when I was in medical school, now I'm going to sound old, um, but that I want to
Yesterday.
say there were 1,000 medications in the U.S. pharmacopoeia.
Hmm.
Um, I think that number today is in the tens of thousands, like 18,000 or some such thing. I mean, no, I'm sorry, it's nine. Right. The number I think is 9,000.
Okay.
And that there are in it, it's almost impossible. You can't keep track of it all. You can't make sense of it all. It's it's way too busy for any one person to put it all in their head. You can't hold it all together. Um, so that, and the same thing is true of medical education, that instead of a set number of years sitting in a seat, staring at lecturers, and then getting a degree, that
Taking a
instead of
test.
taking a test, that instead of time-based education, we're really moving into an era of competency-based medical education. And that the knowledge piece, what is really nothing more than cognitive talent, memory, and pattern matching. These are the three elements of IQ or the intelligence that we were selecting for, and that was cognitive skills, memory skills, and pattern matching skills. A lot of that cognitive work is going to be done for us, especially the pattern matching piece. That it's artificial intelligence is quite brilliant at pattern matching. Um, where it falls down um, with spectacular failure is emotional intelligence.
Hmm.
And that we'll be selecting for people who are thoughtful and emotionally sensitive and capable of doing the the heavy lifting of seeing a patient in their shoes where they stand for who they are and taking medicine and crafting it down to the unique needs of a person. But that doesn't require them sitting in a seat for 4 years. So that we're going to be into, you know, um, a curriculum which is really competence based. That as fast as you can master basic science, clinical science, systems science, artificial intelligence science, um, and then work coherently with other members of your team around the needs of an individual, and you can master these systems skills, and then the communication skills, you know the behavioral intelligence skills, the emotional skills, to bring all of that power and force to the need of a patient. We want you doing that. We don't want you sitting in a classroom. So competence-based medical education accelerates to the need, you know, we're going to get people out into practice.
Yeah.
Case in point, if in your journey in life you were a medic in the army and had combat training, you then found your way into being a nurse and working in the intensive care units. That you had profound amounts of awareness.
Knowledge.
Yeah,
Yeah.
right. You've seen it all,
Mhm.
and that you came back to obtain an MD. Sure. But why would we have you sit in a classroom for 4 years with that skill set? That if you can test out and show that you have the basic science, the clinical science, the system science, and you have the skills training, um, we can get you an MD in 6 weeks. I mean, as fast as you can test out and get through the, take the tests, show us that you know the knowledge, show us that you have the skills, show us that you can work collaboratively with everybody else on the team and understand what they do and help us create better care. Why would we have you just sit in a classroom?
Yeah.
So I think we have to approach it so differently. And that part of this thing, I spend a fair amount of time in AI. You know, it, it's
Yes, let's talk about AI.
right. And that I'm
Well,
so I
I think your presentation, I think we were at Chico State somewhere and doing a presentation, but the ability for AI to see precancer cells forming in your radiology work that the human eye can't see is so amazing. And I think we're not going to go into the AI can be for good because I think that the world has understood AI can be for good, even just from a few years ago when we were first talking about this. And that it's a combination of the human. AI is not going to replace humans in the work. It's the combination of AI with the human, much like flying an airplane is a combination of the computer plus the human, and together they're stronger than either one of the force. Right? I think
right
that we've talked about that in the past as well, and so yeah, I marvel at how much more AI could do to be helpful and expedient in healthcare.
in in our work in a comprehensive breast care center, it just exactly as you explained it, that it is this beautiful moment of it doing all of the tedious drudgery of finding a cancer on a mammogram and freeing me to be back at the bedside.
Mm.
Um, and I jokingly call myself the Wizard of Oz, that I'm the chief validator, I'm the chief integrator, the chief communicator, and the chief orchestrator of the path of care. And that much like the Wizard of Oz, who, when they pulled back the green screen, he was actually facing away from Dorothy, and that, he was actually miserable. He just didn't know it. But that when you turn around and help people, and share the gift of being authentically human again, um, and that's what AI has let us do in the breast care centers, that a synthetic intelligence is allowing us to recapture our humanity.
That's beautiful.
It's a weird moment when you think about it, but that I
Yeah.
can't I can't practice my day without it. It's
Interesting to think about that evolution from pre-computers to then the computers and having to type everything into things, right? So the computers were great, but they took away from you actually being eye to eye with a patient and
exactly
having that connection.
right.
And so now the AI is helping to bring that connection back. That is
Yes,
beautiful.
right. And that I mean, this I will sound old. When we first started in breast care, really it was clinical exam,
Yeah.
and that we were finding cancers that were the size of golf balls.
Because you could feel it.
Right. That was it. It's like, oh yeah, here's a rock hard mass. And that, through the evolution of technologies, we have now gotten to 3D mammography with AI capable of looking literally one tiny voxel of that space to the next, to the next, to the next, and literally burning through a stack of hay. one piece of hay at a time until it finds the needle in the haystack,
Yeah.
because it's brilliant at that capacity. Um, as I gave a, a talk that it shows up before I do. It leaves work after I do. It does not drink, smoke, chew, become emotionally labile. It's just methodically, systematically good at finding cancers. So yeah, I am grateful for this time, and that, but this is just that validation use case scenario of what happens in breast care. Um, this will have similar impacts across the continuum of care.
Everything.
You made a point that humans will not be replaced, and in irrevocable dynamic high risk environments, there will always be a human in the loop,
Yeah.
and that's mostly what healthcare is.
I also remember we've had so many conversations about all of this, but that when you think about the healthcare, interprofessional healthcare campus, part of that campus, and a big part of it, is creating that clinical environment of the future where, and correct me if I'm wrong, but we're gonna paint the picture, right? I'm the patient. I walk in the front door. There's this automatic understanding of my patient history, what needs to be talked about, what, follow up on, whatever. Like it's almost instantaneous. So those steps between, let me fill out a chart on a clipboard, um, let me hand it to them at the front desk, have them input the data, and then have the doctor come in and say, okay, let me review all of these things. It would be instantaneous. And that clinic of the future is really the heart of this interprofessional healthcare campus, because then you're training the next generations of healthcare workers in that environment of the future. Uh,
Yes.
Please elaborate on that and correct me where I was wrong, because
No,
it was a
you have
brilliant exercise to
uh,
go through that with you.
you have exactly right. That is, and we're going to arrive there at shocking speed. You will see this collision of two separate um, tectonic plates.
Okay.
Um, one of them is these very large frontier large language models, that will be enterprise scale logic and reasoning systems required in these large scale vertically integrated healthcare entities. Think of them as hospitals or universities or campuses, because you will need something in that size form to operate coherently across the spectrum of what's happening on the campus. Um,
I'm
and
going to need you to translate that for me.
right, let
Okay.
me walk you through somebody coming to the campus.
Okay.
A a new, recruit or enrollee to the campus will actually be assigned their own synthetic tutor.
Gotcha.
That you will actually have the HAL 2000 uh, assigned as your synthetic tutor. It will know you and where you struggle and how you struggle and what you struggle with. Sal
So
Khan
as
with
a
the con,
learner,
yeah,
not so we've shifted from patient to learner. Gotcha, gotcha.
right.
Okay. All
And
right.
that, will in this competence-based acceleration of students, that every part of your journey will be sort of facilitated and understood and where you struggle and that nobody gets left behind. And that it'll track you through the simulation center and what you've seen and what you haven't seen. And it'll understand the clinical scenarios that you're good at and the clinical scenarios that your team needs, more work at. And that
Hmm.
when you arrive in the clinical space doing clinical care, this sort of same all-encompassing, all-knowing system will be there as your synthetic assistant sitting next to you quietly watching, and you'll never have to touch paper. You'll never have to, write a note. It'll be your synthetic scribe. Um, and that when a person comes to the emergency room, you'll have a conversation with this person and, begin to understand them for where do you live and what do you do and what are you exposed to and what's happening with you and those sorts of things. So that's on the institutional side of how AI empowers the campus down to a provider.
And it goes back to the competency-based
Right.
structure as well.
But at the same time, we're going to flip the frame and look at it from the patient side.
Okay.
So patients don't need frontier level large language models that can recite Emerson and speak Italian and French and, Urdu and everything else. They just need something that will have a form function that will fit on their phone and do the modules that they need in the care of their health. If you're a diabetic, on
Okay.
your phone, you will have your own synthetic diabetologist. And your phone will integrate with your glucose monitor and it'll integrate with your pump. And you can take your phone and take a picture of a meal, and then your phone will say, okay, we got this. But oh, by the way, on the same menu, there is this meal that might might be your choice, unless you just want to celebrate with a pasta carbonara, but that you can choose. It will help you live your best life, and it will do it automatically. And that if this person with brittle type 1 diabetes comes to clinic because there's something desperately wrong, that with your permission, your synthetic healthcare assistant will have a conversation with the emergency room large language frontier model level system. And they'll do an information exchange. And the synthetic intelligence empowering the clinicians will all of a sudden say, oh, did you know, by the way, this person actually has high level gastroesophageal reflux? They've been sleeping incredibly poorly because they have, right, obstructive sleep apnea, and they're suffering, and that, everything about them tells us that they're in ketoacidosis and in crisis and, right. And
Mm-hmm.
that will literally all be known. And that where you go and what you're exposed to and what you do and how you suffer it's a uniquely personal moment. Everybody suffers differently, but we'll be able to understand people down to a person.
Mm-hmm.
And
Well, it's
that
true. I mean, like, it's hard for me sometimes when I'm talking to my doctor about something to describe what is wrong. What is actually wrong? I just like I know something's wrong with my left hip, and this is a true story, but like I don't know what it is. And then I getting some numbing sensations down my leg with it in the last few weeks, and I'm like, okay, like who do I go talk to about this? And so but it's really hard to describe the symptoms because it's not really painful. It's just weird. Well, how do So, yeah.
yeah,
That'd be
exactly,
cool.
right. And that um, we will have more time again at the bedside to understand a person down to the unique problems that this individual is experiencing. They will see them in their native organic state, and that
With the data right there too.
with the data right there,
Yeah. So it's like this perfect match of
right?
information.
Yeah. So it's these large. scale frontier enterprise models operating in the institutions that require them. And then we'll be seeing small scale, small modular healthcare components operating on scale with the patient, to the needs of the patient. And that this system will advocate for the patient.
Hmm.
Um,
Which is also a huge, I don't know,
yep.
risk. I don't know what word to put in it right at the moment, but just trying to help my family members advocate for themselves in a system when they're, either too old or they're
Oh, yeah.
not well or not mentally well, and like,
Right.
we're not the best advocates for ourselves sometimes, even when we're told what to do. Or like, let's just take smoking, right? The doctor says you need to quit smoking. It's what's best for you. And then you have to like figure out how to get through that system to help get the, you know, right behaviors in place.
We will have systems that
Hmm.
will advocate culturally, socially appropriately to the needs down to an individual.
Yeah.
Um, that it will
Precision
be
education.
exactly,
Oh,
and that that the healthcare system, this person's doctor will say, you need to get a head CT, and it's like, how do I make that happen? And
yeah.
that you can ask
Well,
your healthcare advisor on your phone, where do I find one? Where do I find the most cost effective access to it where I can get it scheduled and get it done and get the answer back and be comfortable with that decision? That you will have your own personal health advisor. Um, and so I, there will be a moment when a patient is talking to me and their health advisor is actually listening to the conversation to the benefit of the patient on their phone, and the patient will turn their phone around and it'll say, you know, Dr. Schlund doesn't really know what he's doing. You need a second opinion. Oh, sure. I mean, we not everybody is gifted in the moment of understanding every person, that there are these discontinuities, that this person may be, I don't know, Urdu or raised as a Uyghur or raised in some social where I don't understand the social cultural context of what's happening to them.
hmm.
And that the system may protect the patient in that moment. And we need that to happen. We need to match people to the need.
I
So
also
I'm
like when I envision this interprofessional healthcare campus that somehow that cultural, because there's many cultures and each person is its own their own culture in a way, but where that's another way that we can overcome the cultural barriers as well, because this campus trains for the future, and that would be really baked into it as well.
we'll be selecting for people who are socially aware and very adept at complex social conversations and understanding people down to a person.
Yeah.
Yeah, I'm really looking forward to it. Um,
Yeah. I also think about the overlap of education. So, right, healthcare education is so incredibly siloed. And then there's this incredible impact on clinical education hours. And there's literally not enough clinics and hospitals to put all of the learners into. That's another thing. That's kind of what I'm dealing with as I try to expand graduate medical education in my current work. Where it's like, well, I have this school for social workers that they need their hours, and the radiology techs need their hours. How much you're flipping every clinic and hospital into a teaching center of some kind. And then how does that impact the actual work of the clinicians? So there's just so many interesting intersections. So I think about if you're going to build a medical school, why not a PA program as well? Because this first 2 years of medical school, more or less. I mean,
Yeah.
it's not that easy to say that, but also nurse practitioners. So how to have some efficiency in education as well is always something that I think about. I don't have the answers, but
No, we're going to redesign the system. We have to, because we can accelerate what you're exposed to in the scenarios through, AI empowered, um, that these high fidelity learning centers, these high fidelity sim centers, that you will be. It isn't just sitting in clinic anymore for 1,000 hours, seeing what comes through every day in clinic, that we can actually round out the full understanding of the human condition. Because with AI and high fidelity sim centers, that you can be exposed to all the core clinical scenarios in
mm,
cardiology,
reenacting
gastroenterology, endocrinology, you
infectious
know,
diseases.
infectious diseases, and that, yeah, you can literally say, I have seen all of this. I may not be the master of it, who is, but that I have actually rounded it out. I have had a full and complete awareness and understanding of it, um, and that um, these people will be incredibly competent.
Hmm.
Skills-based skills-based training is different. If
Hmm.
you're going to be a thoracic surgeon, that's an eye-hand coordination, skills-based, and it's not so much doing a cardiac revascularization. Um, if you've seen 100 of those go well, you have seen 100 of those go well, but you need to see 1,000 of them that didn't go well.
Right.
And how do you get yourself out of trouble? There's 10 years in becoming a gifted cardiothoracic surgeon.
Mm,
Um, and the person who opens my chest with both hands, I want them to have 10 years of experience or more.
yeah.
Just, I mean, being aviation figured this out a long time ago,
Yeah.
right?
You,
The,
you had to have a error rate of like zero.
the team-based mechanics matter.
Hmm.
Experience and proficiency matters, that you can't be a senior captain flying into complex, high density environments without just years of experience.
Yeah.
So, on the skills based side, um, competence is, you know, there's Malcolm Gladwell made the case for, 10,000 hours to be a virtuoso. It isn't it isn't 10,000 hours, as you know, but it requires an environment that is valid, where you get positive instantaneous feedback, negative instantaneous feedback, and that you actually retain that proficiency and dedicated skills-based training. Those are the elements of becoming technically adept, at something. And but on the knowledge-based piece, AI and competence-based medical education will accelerate that tremendously.
Yeah.
So that's what the whole campus is about putting all of this together in a relatively small space. And the campus itself, one of the important pieces of the campus is the fact that it's driven as a foundry model, that the regional needs assessment decides what the campus creates. It's a foundry that wherever the campus lands, that the regional needs assessment committee, or essentially is deciding what the foundry produces. And if there are no dental hygienists for, there's, I mean, if the region only has like 1 per 10,000 people, then I think we're going to be having to produce those.
Right, right. That's a really good factor, like you put that in a really good way to think about the regional needs. And of course, we went down the path of with graduate medical education. It was very clear that the Butte County Public Office had said we need access to care and we need mental health care. And then
Yes.
we, as a, Butte Glen Medical Society board, the Growing Healthy Rural California team, um, we went forward and got letters of support that we needed a psychiatry residency. And of course, the campfire of late 2018 just put a giant spotlight on that. It had been chronic prior to the fire, and then the fire had just caused so much trauma. I actually spoke to somebody the other day who is still dealing with their trauma from the fire. So we then went and established a psychiatry residency and then a family medicine residency. And that doesn't need a building, right? Well, I mean, Enloe that did create a family medicine residency clinic in their hospital. But I mean, it's interesting to then hear, like in rural areas, they need all of it. They need every single level person type of healthcare worker. And that to me, the Interprofessional Healthcare Campus became that beacon to tell people, the youth of the area, look, you can do this. It's right here in your backyard.
Exactly.
You can't create a campus or a medical school in every single town, but to have that, you're basically building the beacon of what could be, and it's actually economic growth as well, and that's another topic for another day. But
Well,
it's
it's true.
it
The French
it's a
economist,
yeah.
yeah,
Go ahead.
no, you're absolutely right. That I think it is to the French economist Jean Baptiste say that if you build it, they will come. And
That's a
that
movie. Field
right,
of Dreams.
and that to your credit, that graduate medical education landed in Butte County and started creating people in behavioral health and psychiatry when literally none existed.
Oh, no, no child and adolescent psychiatrist north of Sacramento into the Oregon border.
Exactly.
They might
Right.
have been there, but they weren't practicing or they were commuting someplace else. And so I'm excited for the next phases of a child and adolescent psychiatry
Yeah.
fellowship, but that's another topic.
We
But yeah,
can.
it really was an education for me on the importance of having education closer to home to really inspire youth to see what's possible.
Oh yeah,
Um,
and to your credit, this is of course not lost on you, but that more than 50% of the people who are garnered from a rural community, educated, and then essentially allowed to go practice in that community, stay in that community.
yeah.
And
Oh,
so,
here's another data point. You're gonna like this. Okay. A physician from North Carolina was speaking to the Comet Collaborative, which UC Davis is running, and it's support for all GME in Northern California, Southern Oregon. Anyway, so this physician was sharing that they have found 62% is of the retention rate when you have UME with GME. Sorry, I have a lot going on in my brain right now. UME and GME together leads to 62%. So all the work that you all are still doing in Butte County is really solidifying that retention rate.
no, it
Yeah,
works.
it works.
And that's what the whole idea about the campus is that um, this campus potentially sits on as little as 6 acres. Um,
Mhm.
it doesn't actually have a gigantic footprint per se, and that it creates a wellspring of certificated providers of healthcare to the needs of the region. And it will be constantly redesigning itself around what that needs assessment directs. And so its work will never be finished.
Again, with the let's build something, but it's never done.
That's the absolute fun of it all, because so many of our historical legacy institutions are cemented into the history and legacy of the past, but they have a difficult time innovating, um, and keeping up to the now. We need a campus that has historical roots, it has legacy. The collaboration to the universities and the academia matters, but that the campus itself has to embrace, we have to do something different if we're going to fix the future.
Yeah. Well, I don't want to take too much of your time. Is there anything else that you
No,
wanted to say? More
just
comment?
appreciation for the opportunity and the collaboration, Kristy. It's just a joy to work with you.
Same here, and I'm looking forward to our March visit in the Central
Yeah.
Coast. And yeah, you get to meet the founder of the PA program, Dr. Alfred Sadler, and with his twin, Blair. They were the ones who helped develop the PA program. So
Oh,
big ideas.
yeah, it's a rich and vibrant future. I'm looking forward to it.
Me too. All
Thanks,
right, we'll
Kristy.
talk to you soon. Thank
Talk to you
you.
soon. Okay. Bye.
Lost my sense of humor, I found them too fun to know. Hovercrafts, blow up kayaks, would have helped with angry toes, but it gave mashed potatoes. Take that meatloaf back, hi. Birthday dehydrated cake and box of wine so nice with clean dark hair.